We have Dr. Frans Korb, who is a psychiatrist and a clinical psychologist, as well as a SADAG board member, and been part of the SADAG family for over 25 years, specializing in all mental health issues. And he's really going to be helping us to unpack the diagnosis, assessment, treatment, even medication around anxiety and panic.
Yeah, thank you very much, Cassie, for that introduction, as well as the invitation. Thank you as well to the other people on the panel with me. And I think all of us, Zane, Kerlinda, Cassie, yourself, has come a long way in SADAG with all the years, and we've seen it grown over these many, many, many years. And I almost thought when Zane asked me a few weeks ago to talk about panic, this is almost our foundation, because the person that started the SADAG was the one that suffered from panic disorder. So that is why I thought, no, this is such an important topic. I just have to be in and do this. And sorry, everybody, I'm sitting here with a bad flu, so I hope I'm not going to cough and splutter through this whole next 10, 15 minutes. So in this next 15 minutes or so, I'm going to deal with the kind of medical aspects. And then, like she said, that Kerlinda will deal then more with the psychological aspects. So some of the slides I'm just going to go through very fast, just to give you a kind of a background about panic disorder. Now, the first thing we need to stress, and I see that was in the kind of circular that went around to invite people as well, that we need to remember that anxiety is a normal feeling. So anxiety is not abnormal in everyday life, because anxiety is there really, it's part of the fight-flight response, and it's there to kind of protect us and to make us function. You know, if we didn't have any anxiety, we will not be able to really be scared we will do anything we want to. If you weren't anxious, you will not study to write exams. If you weren't anxious, you will just walk across the road without looking if there are cars oncoming. So anxiety is part of that fight-flight response, that protective response. But then when does it become a disorder? And I've just tried to write it there in very, very simple terms. So anxiety, normal anxiety, is that kind of a vague feeling of apprehension and nervousness. But when you feel that anxiety gets out of control and it's taking control of your life and it starts dominating your life, that is the point where we then say that it's becoming a disorder. And that's the same with all feeling blue or feeling depressed. It's the same kind of thing. If you start feeling that the depression is starting ruling your life, is the most prominent symptom or the most prominent feeling, emotion you've got, then that is a depression. It's quite common. There you can see all the anxiety disorders. There's lots of statistics about them, but there you can see how common they all are. And there is panic disorder is up to about 5% of the population will get it. And that's quite high. That means at least about 5 people out of 100 will have significant panic disorder. Remember, we've got the kind of classification systems, or which gives us the criteria about all the mental disorders, and the main one is the DSM, the American Diagnostic and Statistical Manual, and the other one is the ICD, the International Classification of Diseases from WHO. And panic disorder is one of the anxiety disorders. So just to put it in context, that we do have all the others where anxiety is out of control, like PTSD, OCD, phobias, GAD. But tonight we are really focusing very much on panic disorder. And it's really panic disorder. The symptoms are in a way very much the same as anxiety, as GAD. But what happens in a panic disorder is those symptoms are which you then experience through the whole day in GAD is compressed into a 10, 12-minute period. So whatever you would have felt over a day will now just be compressed into a few minutes. And that is why the symptoms are so severe. And you almost feel like most people that you're having a heart attack. And that's why lots of these people land up in casualty, being examined for and investigated for a heart attack. And they find that it's not a heart attack. So there are lots of causes of anxiety disorders. I'm not going to stand still with these things. So I will deal basically with medication, which is the biological part, the brain functions and chemistry. And then Kerlinda will deal more with the kind of psychological factors, the kind of conditioning, observational learning, and how CBT and all of that helps with anxiety disorders. Just to preempt this whole thing as well, as when we look at the treatment of anxiety disorders, it's very important, and I know it's perhaps expensive to have medication and see a psychologist, but with anxiety disorders, that is often the best treatment, is to go for both medication as well as psychological treatment as well. Anxiety is very complex. There are lots of brain parts that is involved. There you can see a panic attack primarily starts in the brainstem, and it's that kind of totally exaggerated fight or flight response which causes a panic attack. But there are all the other things as well. If you then look at the kind of chemistry, and that is why I put it up here, because lots of people, when I give them a medication and we primarily use the antidepressants, they say, but I haven't got depression, I've got a panic attack, or I've got generalized anxiety. Because the neurotransmitters, there you can see the neurotransmitters in the brain that has got to do with anxiety, with panic attacks. It's noradrenaline, serotonin, plus then GABA. And, you know, all our antidepressants basically work on serotonin, and some of them together with noradrenaline as well. And that is why we use, and that is why the antidepressants work well for the management of a panic disorder and other ones. The last point there I want to just highlight as well, that we need to remember we often see people coming to us with excessive anxiety or panic attacks. And then we realize it's not really a disorder underneath, but it's other things, that they drink a lot of coffee, what we call caffeineism, where the high levels of caffeine they take in provides anxiety. Energy drinks, the Red Bulls, the Monsters, all that stuff, that's also caffeine can do it. Sometimes medication withdrawal substances can do it as well. There are lots of medical conditions that give anxiety. So when we examine or look for the diagnosis of a person that arrives to us with severe anxiety, we need to always exclude the physical causes. And there are lots of physical causes, especially thyroid, anemia, asthma people when they go into an asthmatic attack. So there's lots of that can cause. And obviously, we need to treat the underlying medical condition that causes the anxiety if we pick one of those patients up. So just a definition of panic disorder. Like I said, it's characterized by the sudden bout of intense, unexplained anxiety. And that is why we always ask patients, do you get it out of the blue, or is it in a relation to a specific event? So this, and panic disorder, it usually happens totally out of the blue. And they said, I don't understand it because I was driving and I just had this panic attack. And lots of the symptoms are the physical symptoms. And on the next slide, I'll put up the kind of symptoms we get. And it can happen quite a lot, several times a day. Sometimes people are lucky it only happens now and then, but people can have repeated panic attacks through the day. There you can see the kind of clear symptoms. It's that kind of palpitations, that they're racing, pounding heart, sweating, trembling, shaking, chest pain, and that is often what people think, that they're getting a heart attack because they get that chest pain, abdominal pain, nausea, numbness and tingling sensations. That often comes from the hyperventilation and gasping for breath when you get the panic attack. Chills, hot flushes, shortness of breath, feeling of choking, feeling dizzy, lightheaded, fainting, this kind of derealization that you feel unreal, detached, depersonalizing. And often people when they get the panic attack, they said, I just feel I'm going crazy. I'm losing control, to the extent that they often say that they feel they are dying. You might have heard about the work with agoraphobia, that sometimes you get agoraphobia attached to a panic disorder, panic attack. And agoraphobia is when the people reach that kind of situation where they actually want to stay at home. They don't want to leave their home because they're so scared of getting another panic attack that they will not be able to kind of cope with it. So that is in essence what, if you see that term agoraphobia, panic disorder with agoraphobia, and it often happens. So really, when we use medications for a panic attack or panic disorder, the idea is really that we try and with medication to block the panic attacks. We often, like I said, we need to treat the comorbid things. If there's other depression, medical conditions, substance abuse, obviously that must be treated first. And then we want people to hopefully be symptom-free, that they don't get further panic attacks, and that they must remain well. So, that also means that when people go on medication, that they need to stay on medication for a sufficient period of time. I get patients, then they take it for 2, 3, 4 months. Hopefully their panic disorder is well controlled, then they stop it. And then 2 or 3 months later, the panic attacks come back and they come and see me. They said, but I took the medicine, but it came back. So, unfortunately, with these things, you need to take it for quite a bit of time to make sure that the textbooks often say you can think of stopping your medication or phasing your medication out rather if you've been symptom-free, if you haven't had a panic attack for at least 6 months. So that is the kind of thing. But so you need to take it until you've been in good remission for at least a period of 6 months. So the medications we usually use, and I always explain it to the patients, there are 2 ways of dealing with it. The one way is we need to act prophylactically. So we need to try and get the disorder under control and prevent the attacks from happening. Now, there we use the antidepressants, like I said, because the neurochemistry of anxiety and depression there's a lot of overlap. And the most commonly used ones are the SSRIs, and you might know them. That is the paroxetine. There's about 6, 7 different SSRIs on the market, but just to say that some of them work better than the others. Old paroxetine was the first one that showed quite effective, and then sertraline, and then escitalopram is quite good because they've got little side effects. Sometimes fluoxetine can work as well, but not as good as the others. If we then find that the person is not well controlled on the SSRI, we can then go over to the SNRIs. That's the dual-acting ones that works on serotonin and noradrenaline. So the antidepressants are the choice because they are the ones that we can use to prevent, to get that disorder under control. People always ask me about benzos, and I love the benzos because they make you feel so good. The benzodiazepines is only used in an attack. So what I mean with that is that when a person feels the panic attack coming on or the panic attack starts, they can take then a benzo and that is things like the Urbanols and the Alzams and the Xanols and all of those kind of ones that we use to abort an attack. But the benzos are not the ones that we want people to use all the time because you get used to them, then you have to increase the doses, and they've got lots of side effects, which I'll show you on the last slide just now. So we don't want, and the best one to use to abort attack those, there's only one on the market really, and that is Ativan sublingual. So it's a small little white tablet that people need to carry with them all the time. And when they feel the attack coming on, they take one and put it under their tongue, and then very quickly it melts away the attack. But that is the acute situation. In the prophylaxis, the prevention, we use the SSRIs. Okay, there you can see, just to stress again, the antidepressants, the benzos, and then just to emphasize again what Colinda is going to talk about, the CBT and all the psychotherapy techniques. My last slide here, and that is what I want people to remember, the benzos, the tranquilizers, they've got lots of horrible side effects if one takes too many of them. There you can see, for instance, the benzos cause drowsiness, they cause dizziness, they cause psychomotor dysfunction and incoordination. People they cause headaches, blurred vision, they affect your memory, they can have an opposite kind of effect, which is called disinhibition or excitability. So I put that up there just to also emphasize that we really don't want people to take benzos all the time and rather stick to the antidepressant type medicines to control.